Hello, and sincere thanks to everyone for being here tonight to join us for our Mid-Atlantic Urology presentation on what I think is a really important high-yield topic for many men, which is understanding diagnostics and treatment options for the enlarged prostate gland or BPH. So we'll, without further ado, get into kind of our discussion. I'm Dean Laganosky. I'm a minimally invasive surgical specialist working with Mid-Atlantic Urology, board certified urologist. My practice is located primarily in Plymouth Meeting with some outreach towards Masons Mill and Sellersville. I really specialize in complex voiding dysfunction, minimally invasive surgeries for both benign and malignant conditions, both inside and outside the urinary tract. So we're going to be talking tonight about BPH, which is really benign prostatic hyperplasia, which is a condition that affects many men, particularly as we're aging. So it's really important for a couple disclaimers. This is really not a cancerous growth of the prostate gland, but a benign, normal growth of that prostate gland that can create some difficulty with urination and symptoms related to that. It's a very treatable condition. And really what we try to focus on is what is the best tailored option for you as a patient when you come and get an evaluation with our urologist. And it's very common, so much so that about 50% of individuals over the age of 50 will suffer from some degree of BPH related symptoms. And then about 90% of individuals over the age of 80 may have some BPH related dysfunction. What contributes to this? There is a normal age-related growth of that prostate gland. So I generally will counsel patients that if you live long enough, you're likely to have some issues related to your prostate gland. There are some genetic predispositions, meaning that big prostates can run in your family, and similar to a brother or a father, you may also have a large prostate gland. And there is also some hormonal influences such as testosterone that cause that prostate gland to grow. So I generally will kind of start out with this depiction of the prostate gland, a normal prostate and lower urinary tract on screen left, and then an enlarged prostate gland scenario on screen right. So in the prostate gland scenario where that prostate is not very large, think about that prostate gland like a ball surrounds the urinary tract. As it's growing, it's not only growing outwards, but also growing inwards and impinging upon the channel where you're urinating through. In a normal situation on screen left, you're able to pass that urine freely through the small channel that remains on the inside of that prostate gland. Your bladder is not strained to pass that urine, and you're no longer, collecting urine on the inside if you're compensating well for this. In situations where you are having issues related to your larger prostate gland, that prostate gland is starting to swell within that channel. That opening is becoming less and less through that prostate gland. And you can see that the bladder tissue here becomes a bit more strained or stressed, trying to generate a force to get that urine passed out past the prostate gland. You will also have situations where the urine may not be able to completely empty, which also creates issues in and of itself. So what are some common symptoms related to that enlarged prostate gland? You may have rather profound sense that you have to go to the bathroom. You can't hold your urine. That urge to urinate becomes more and more frequent and less deniable. You may have some difficulty with waiting around to have to start your stream, generate enough pressure, squeezing your bladder against that prostate gland to get things started. You may have a situation where that urine stream actually cuts off or tapers off and then starts back up, again, related to the pressure dynamics against that prostate. Frequent urination, particularly at night, is one of the most common symptoms of BPH. Nighttime tends to be the most troublesome time for a lot of patients because that bladder, like any other muscle in our body, is a bit more fatigued and more sensitized at night. So you're going to feel these symptoms a bit more with any kind of standard pressure on that prostate. And then, you may actually have situations where you strain very hard to have to start that stream or sustain that stream. It could become painful in some situations. We have situations where you may not be able to completely empty that urine past that prostate gland if your bladder is not able to generate enough of a pressure. And then this can also contribute to difficulties holding urine or controlling any leakage of urine. So some other complications of BPH may be if that muscle tissue is too stressed or strained, you may actually leak urine, or if you're holding on to too much urine behind the scenes, urine will actually kind of seep out at times that you don't expect. Um, Urinary tract infections are another common complication of BPH, so much so that the number one risk factor for men to get a urinary tract infection is incomplete bladder emptying. Um, Bacteria tend to build up in the urine that's not fully emptying from the bladder, and that can be a source for this. Similarly, bladder stones, which can be very painful, hard calcifications in the bladder, form from the stasis of urine. The particles that normally get passed out with the urine have an ability to collect, clump together, and then calcify, creating pain, blood in the urine, or otherwise. In some situations, your bladder is so stressed or strained that it actually becomes damaged. And high pressures, we know on the urinary tract over time, are not benign. So getting out in front of this, learning early on before or early on during when some of these symptoms are starting is really critical for helping to keep that bladder nice and healthy for years to come. And in some situations, if that urine back pressure is so much, you may actually back up urine towards the kidneys, causing kidney damage, and in some situations, permanent kidney dysfunction. It's a really important distinction, again, to note that BPH, or an enlarged prostate, does not necessarily independently increase your risk of cancer in the prostate gland. These are two kind of different processes that go on. So how do we diagnose BPH? There are a couple initial screening steps that are very helpful, many of which, when you see a urologist, we would walk you through. Digital rectal examination is a quick finger examination in the office from down below. This allows us to gauge the size of the prostate gland, as well as any lumps, bumps, nodules, or irregularities that we would have to look into a little bit further. Bladder scan is a quick, simple ultrasound measurement in the office. It takes all of about 2 to 5 seconds to do this. After you've gone to the bathroom, it would measure how much urine is trapped behind at that given time to give us a window into how well you're emptying your bladder. It's not a perfect measurement, but helps us to give us some information to guide you along the way. Symptom scores. So these are some urine symptom screening charts that you would fill out to let us know in more detail what types of symptoms are you really experiencing with your urination, whether it be urinary urgency, nighttime urination, a delayed urinary stream, intermittency. And then it also has a score, 1 to 6, as to how unhappy or bothersome these symptoms are becoming to you for a quality of life measure. It really helps us to also have a moment in time where we know where you are, so we can compare that baseline to future as we do interventions or we're monitoring over time. PSA blood test is a quick, simple blood test that looks at a particle that comes from the prostate gland. This can be an indication, if those levels are high, low, or normal, of whether or not we need to do any additional screening for prostate cancer or otherwise. I always say that PSA is prostate specific. It is not cancer specific. So there's many things that can cause PSA to be abnormal. Important to partner with your specialist on this. And then urine testing, including urinalysis or a culture, can really show if there's any bacterial presence in the urine, if there's any irritative change, microscopic blood in the urine, other things that we may need to address or consider in your treatment or workup. So there are other kind of more specialized tests that we oftentimes employ to get an idea of exactly how a patient is doing when we're dealing with workup for urinary symptoms or BPH. So one of the really powerful instruments that we have is something called a Eurocuff. It's a little bit more sophisticated than Euroflow, which is basically pee and let us know what the flow rate is. Eurocuff is a quick, non-invasive test that we do in the office. It takes as long to do this test as it takes you to pass the urinary stream. It has a cuff on the tip of the penis that squeezes on and off with some smart resistance against the way that you pass the urine. It basically works out that bladder, and it tells us how much pressure is your bladder needing to generate to get that urine out. Is that pressure okay at a safe level? Is it too high or is it not enough? And then what the flow rate is at those different metrics. It can really give us a very clear window into how functionally you are avoiding, and if we need to consider other things to manage your bladder and your prostate gland that you can't necessarily pick up because they may be happening silently in the background. So it's a really good screening test. Kristen, let's go ahead and play that Eurocuff video.
Performing the test is simple. Instead of using a catheter, bladder pressure can be accurately quantified by identifying the pressure necessary to stop urine flow via the Eurocuff. Additionally, surface EMG electrodes can be placed on the abdomen and the perineum to quantify abdominal straining and dysenergic activity. The patient is then asked to urinate through the Eurocuff into the flow meter. Throughout urination, the Eurocuff simultaneously applies pressure to the urine stream while evaluating resulting changes in the flow rate. The pressure required to interrupt flow equates to the bladder pressure.
Great. So look, some of the technical details there are really helpful in terms of us determining how well you're doing functionally. And again, are you in a safe range, or are we keeping you in a safe range? And also as a baseline for comparison as we go forward to know more objectively how you're doing and to help to guide you with some objective information to make informed treatment decisions. Urodynamics is a bit more of a sophisticated test that we sometimes employ. This one does also gauge how functional your bladder is. In some situations where you may not be able to urinate well on your own, this does require a catheter briefly inserted into the bladder. We fill up the bladder, we read similar pressures as we're filling and as we're emptying, and we can get a good idea of functionally how you're doing. The Eurocuff provides a really good non-invasive option that can give us a lot of that information for most men. And then there's some additional testing. We can actually take a look with a camera to see exactly anatomically how that prostate gland is forcing itself on that urinary tract. We can also, with a cystoscopy, evaluate not only the prostate gland, but also the outflow tube from the body that comes out through the penis, the urethra, as well as the bladder itself. So not only would it tell us the shape and the contour of that prostate gland to help us to select some therapies if we're going that route, but also other things that could be causing a blockage. Scar tissue or stricture is another common source. Swelling or inflammation or pockets of irritation. Stones or any tumors within the urinary bladder can be seen very clearly with this quick 30-second to minute camera look under local anesthesia. Infection sources or bleeding sources is another common reason we do this type of camera look, and any bladder irregularity. We can actually see and get a gauge as to how healthy that bladder tissue looks. Diverticulum actually referred to when that bladder is strained so hard over time, you may actually get a thinning of the bladder wall that causes it to kind of balloon outwards. The muscle tissue is not as strong in that area. And then trabeculation is kind of a gradation over a spectrum of how strained or stressed that bladder becomes when there's an outflow blockage like the prostate gland. So transrectal ultrasound is also a way that we can gauge something a little bit different, the size of that prostate gland, and to also look at the prostate internally to make sure all the tissue looks regular. An MRI of the prostate gland sometimes is another imaging substitute. Size is an important criteria because certain options, minimally invasive or otherwise, are more advantageous to think about with certain size prostates than others. So now that we've done an overview of BPH, we're going to talk about some more specific treatment options. We're going to start with some of the least invasive things like lifestyle changes and medications to avoid. We'll talk about then some kind of more robust therapies if you're having symptoms related to your BPH medications, and then some really good minimally invasive procedural options that actually in many cases have become first line side by side with medication. So, in terms of lifestyle changes, there are certain things that you can do to help to manage symptoms related to your bladder avoiding issues. This involves bladder training. Things like if your body is telling you to urinate and gives you an urge very frequently, you can do something called urge suppression, which is trying to hold that urine safely and comfortably for a bit of time to help that bladder to retrain. The problem is that if you still have that source of that prostate gland putting too much force on the urinary tract, that may be a harder thing for you to manage. Some individuals double void, meaning they go to the bathroom, they take some deep breaths, they relax, and then they try to go to the bathroom again to more completely empty their bladder, reduce the likelihood that urine will build up. That will make them go frequently to the bathroom. But again, may not always be feasible based on what you're dealing. Many men fight an uphill battle against their anatomy and their physiology. And so it's important, if these things are starting to happen, to really engage with a provider and then kind of talk with us about some relatively straightforward ways that we can help to reduce that and keep that bladder healthy. So you can also reduce the intake of liquids after dinner time. What you put in does have to come out at some point, and that generally takes about 2 to 4 hours for most individuals. You think about that the body like a water column. What you fill, there's constantly fluid getting pushed to the kidney and down to the bladder. Regulating fluid by about 8 ounces or less after dinner time may make a big difference in terms of nighttime urination regulation. And then what you eat and drink actually matters too. Certain things are known irritants to the bladder, can make you go more frequently or urgently. Think about things like caffeinated beverages, coffees or teas, carbonated beverages, alcohol, which is a diuretic as well. More kind of acidic types of foods, citruses, as well as spicy or sugary beverages can really sensitize that bladder, particularly if you're already dealing with issues related to your prostate gland and higher pressures. And then lifestyle changes. There are certain medications to be aware of that may tip you in the wrong direction with urination. Think about things like anti-allergy medications, decongestants, some mood stabilizing agents, and things that can be constipating. All of these can affect the bladder in terms of slowing its ability to empty and create some hardship for you in terms of being able to urinate. Many men try to avoid some of these medications or know certain things that they need to stay away from. Constipation, there's a lot of interplay between the bowels and the bladder. If you are backed up or constipated, it will push on the prostate and the bladder and make it harder for you to empty, and vice versa. So managing constipation is key. And then, I also just caution individuals about putting too much stock into some of the other over-the-counter options that are typically presented as kind of panaceas or, major fixes to the way that your prostate gland is interacting with your urinary tract. I think it's helpful, if you have a supplement you're considering, to always engage with your provider to make sure it's a safe and efficacious thing for you to be pursuing. Medication therapies, are really options that help that prostate gland for mild or moderate symptoms. So alpha blockers are really a class of medications that relax the outside of that prostate gland. Use the analogy of that ball surrounding the urinary tract. By relaxing, we're creating a wider channel. The urine should, in theory, flow a bit easier. It's important to note, though, that many people who are on these medications, when you come off, you actually may only see a temporary effect off those medications, and you may need to find that you're going back on those medications to achieve that relaxation again. 5-alpha reductase inhibitors are medications that kind of work more slowly, and they shrink down that prostate gland over about a 3 to 12 month period. These are things like Proscar, Avodart, whereas the other medication classes, Flomax, Rapaflo, Uritraxol, Hytrin, Cardura. Some people use combinations of medications to get the desired results. It's important to note, though, that medications are not for everyone. And medications also have their own kind of side effects. These are meant to be lifelong maintenance medications in most cases. So if you're on a medication and you're interested in potentially getting off of those, you're seeing adverse side effects of those medications, or the medications are not getting you to where you need to get to on testing or otherwise, really we have some safe and very good options for you to consider that could get you off of medication therapy and do what medication therapy does, just better. So we'll go into some of these options now. So there are some minimally invasive procedural options that we consider that can give you long-term sustainable relief related to your prostate gland. So, again, if lifestyle or medication are not getting you to where you need to get to, if medications or lifestyle changes don't seem desirable to you, or you're experiencing side effects, there are a lot of good options outside of those things. And also, another important class of things are if we're monitoring your urination more objectively with Eurocuff or otherwise, and we're seeing high pressures despite medication, you may not see the symptoms quite yet of what that pressure is doing to you, but it is affecting that bladder over time. I oftentimes say high pressure on the bladder is like walking towards a cliff edge. Many times your body compensates well for it until you get right to that cliff edge. When you start to tumble down that cliff and that snowball is rolling down the hill, it becomes a bit more difficult to walk that back up. So we want to be proactive as opposed to reactive, in my mind, when we're approaching the prostate gland and many other medical conditions. It's important to note, too, that we're always going to check to make sure that these procedures are covered through your insurance company. We do benefits verification. So I don't like surprises. We don't like surprises just as much as you don't like surprises. So the UroLift is a minimally invasive option, first one that we'll cover. Think about this like an implant surgery for the prostate gland. Everything that we're talking about, with the exception of a couple of things, will be through the penis, so a camera procedure, no incisions on the outside of the body. You can do this under local anesthesia or while you're asleep. Procedure takes about 20 minutes or so to do. This pinning of the prostate gland is almost like moving curtains away from the stage to open the channel through that prostate, let the urine flow more effectively. It requires typically minimal catheter time after the procedure. This is a tube that helps that urine to drain and lets the swelling go down from the procedure. So my standard protocol is typically 1 day with a catheter. You come back the next day, get that catheter out. Show you the next slide here. So you can see kind of the diagrams on screen left here. We go in with the camera, we put a couple strategic flexible implants that push that prostate gland to the side, and then we create a channel where there wasn't previously one. In my mind, UroLift needs to be done on very specific shapes of the prostate gland, so it's important that you do that workup, engage with your provider as to whether or not this is going to be an effective option for you. The common things that you'll see with a lot of minimally invasive options, and these are temporary, but you'll have some irritation with urination during the recovery process. If your bladder is irritated, it's going to tell you have to go frequently or urgently to the bathroom. Typically, this will last a couple days to a couple weeks. With UroLift, there's pretty minimal blood in the urine, but you will have a red or a pink tinge afterwards for a couple days to about a week. Burning with urination, again, comes from a little bit of that irritation. There are medications we give you to take the edge off of that for many of these symptoms. And then there's really no effect on any ejaculation, which is what the prostate gland is really a fertility organ. So with this one, because we're just pinning or doing small needle punctures, not really much effect on the ejaculation, really no effect on the erections with this or many other procedures. And then you can get back to activity pretty quickly after this. It's important to note, though, that we're not really doing anything to the prostate tissue to shrink it or change it. We're really pinning it out to the side. So an important consideration here. Resume is another great minimally invasive option for a lot of patients. This is a procedure that we do under local anesthesia. Numbing medication goes in. The procedure takes about 20 minutes. Again, camera-based through the penis. We, in this case, are actually affecting the prostate tissue. We are putting a heated steam into the prostate gland at a couple strategic locations through this camera. That steam creates some inflammation. And the analogy I typically use is think about that prostate gland as a grape. This is shrinking it down to a raisin. That inflammation is not the enemy. It's actually what does the work here. So there's no resection or cutting with this one necessarily, but that steam will cause an inflammatory response in the prostate gland. With that irritation that's there, it takes a bit longer in most cases for Resume patients to see the results compared to some of the other minimally invasive options. But it's very good in terms of shrinking down that prostate gland, about 4.4% retreatment rate at about 3 to 5 years. Again, irritation is the most common symptom you're going to have with this, probably a little bit more pronounced with this therapy than a lot of the other minimally invasive therapies because inflammation is there. There are ways that we can turn down that inflammation sequentially, but we don't want to do that too soon as to not limit the efficacy of what we're trying to get done. Burning with urination, some debris passage in the urine. In this case, there's really minimal effect on ejaculation too, 1% or less, but you may have some pain with ejaculation or irritation or inflammation of the prostate. Urinary tract infection is a low but possible risk, as is that inflammation causing some narrowing or contracture along the urinary tract. In rare circumstances, would you need that catheter back afterwards? The typical catheter duration with this is about 5 days in my hands. TURP is kind of the classic gold standard first to market minimally invasive surgery for the prostate gland. This has been around in different iterations for several decades. Think about this like coring out an apple. We use a heated loop while you're asleep. It takes about an hour or less to do this. And we gently kind of core out piece by piece a channel through that inside of the prostate gland, widening that donut hole, so to speak. It's a proven effective therapy. It does use heat throughout the prostate gland, which is a consideration. And in modern day, there's a lot of other minimally invasive options that we consider alongside TURP. TURP is done typically under sedation anesthesia. In my hands, it's typically an outpatient procedure, hour or less to do this. My typical catheter duration is about 1 day after this surgery. So the biggest risk of TURP surgery compared to some of the other minimally invasive things out there is that it will cause decrease in ejaculation in about 75 to 80% of men. Sometimes that is temporary, but sometimes that can be sustained long term. So that's something that we would monitor afterwards. And a lot of times it's just because we're applying heat throughout that prostate gland. There is basically minimal to no effect on any erections with this, similar to other minimally invasive options. You will have some blood in the urination because we're physically coring out a portion of that prostate gland for several days to several weeks, and burning with urination, both from the heat therapy as well as the resection. So we kind of covered some of the basics of some of the older types of minimally invasive options. We're going to get into some of the more exciting kind of newer innovations in the space as well. So aquablation, we'll start there. This is really a very sophisticated, kind of high-level robotic controlled procedure with very high precision to clear a channel through that prostate gland by vaporizing that tissue. Think about the analogy of using a pressure washer under robotic control on that prostate gland. Again, it's camera-based. There's no incisions to do this. This water jet does not really have any heat applied to it as well, which will help in terms of the healing process also. So under real-time ultrasound while you are asleep, hour to do this procedure, we direct this robotic instrument under high precision to hit all the areas of the prostate gland that are causing the blockage while leaving everything else intact. We can clear a channel from the base of the prostate quickly to the apex of the prostate and do so efficiently. We use a little bit of spot heat treatment to seal the areas up. We do have a catheter in place for this procedure. This one will typically be done as an overnight stay at the hospital. Most individuals are home by about 10 to 12 the next day. We rinse out the bladder with a little bit of liquid. Catheter duration for this is 3 days, up to 5 to 7 days if you were having some previous voiding issues. So we would help to work on that with you. But 3 days is pretty typical for the catheter here. So again, effects here, you're going to have some burning with urination, a feeling that you have to go to the bathroom frequently or urgently, and blood in the urine. Your urine's going to look abnormal for several weeks after this. It's going to look red or pink tinge, something to prepare yourself for. It's normal to get some blood clots out with urination, as well as some tissue debris. Again, will improve over the course of several weeks to several months. There's really no impact on erections. Basically no impact on continence either. We map this ultrasound so precisely that we avoid all the other structures that can also affect ejaculation for men. So whereas TURP had about 75 to 85% of individuals with some decrease in their ejaculation, about 9 out of 10 men preserve ejaculation completely with aquablation. 2 to 8% all comers would have some type of decrease in their ejaculation. And the other nice thing about this is you can treat very large prostates just as well as you can treat very small prostates with this type of procedure because it's so precise. It's really prostate size agnostic. There are some exceptions to that with very, very big prostate glands where some other options may be a bit more efficacious. Optilume BPH, this is really one of the newest innovations to the field of BPH. It's very favorable as a potential first-line therapy that's very minimally invasive. So there is no cutting, there's no heating, there's no burning with this procedure, there's no resection, there's no implantation, essentially. It does require some sedation to have you nice and still. We, through a camera, apply a balloon that dilates that prostate gland, creates a wide channel, and then a second balloon that delivers a medication directly onto that prostate tissue. I'll show you some diagrams of this in the next slide. It takes about 15 to 20 minutes to do this procedure. Typical catheter duration is 2 days with this procedure, just to let the swelling go down afterwards. So if you look at screen right here, what we're looking at is we thread a very thin wire that has this balloon port attached to it. We put our first balloon in that dilates this prostate gland, creates a wide channel, deflate that balloon after 1 to 2 minutes. We then pass a second balloon that is inflated for 10 minutes. When that balloon gets wet and gets expanded, it has a medication that stops the cells of the prostate gland from regrowing into that space that are delivered directly onto the prostate tissue in a very precise fashion. And that's what then goes to work for us over the course of several weeks to sustain that wide channel. So the medication is paclitaxel. It's a well-described medication. It's been around for decades now. We use this in a lot of different varieties, everything from injection therapy to autoimmune conditions to even cancer therapies. But it's very effective in terms of stopping the cells that it's interacting with from regrowing in that space. And the nice part about this is it stays confined to just the urethra, really no systemic absorption. So again, a very good option, minimally invasive as it comes, and can be used as a first-line therapy for folks not desiring medication or to supplement medication. It's out of all minimally invasive options that are transurethral, probably the least recovery period alongside UroLift. There's very minimal dysuria or pelvic pressure comparatively that you feel with this. Again, medications can be given to take the edge off of that. Some blood in the urine afterwards can be expected, pink or red tinge, but less disruptive than a resective procedure. Some pain with urination or burning sensation can be expected. Urinary tract infections are fairly rare after this type of procedure. And if anything, offloading that prostate gland should help to reduce the risk of UTIs over time, which is another reason why people do this. And it may cause some swelling. That's why we have that catheter in for 2 days to let that swelling go down, optimize that voiding trial. And frequency or urgency, again, can be expected for a couple of days after the procedure. But really back to activity as usual pretty quickly. Robotic simple prostatectomy is really something that's kind of reserved for very large glands in our practice. So this is an incision-based surgery done with robotic control. It would be one of the most effective options for removing the bulk of tissue that's causing that prostate blockage. Again, there is a recovery period with this because it's incision-based, about 4 to 6 weeks with some downtime. You do have a catheter in place, typically for about a week afterwards to let all the tissue really heal, and does require general anesthesia with a few nights in the hospital. This, because we are removing the bulk of that prostate tissue, will cause ejaculation decrease or absence in some patients. Risk of urinary leakage, even for very big prostates, is 5% or less. Blood in the urine can be expected afterwards, even for several weeks. Burning sensation, frequency to urinate, urgency while that tissue is healing. A low risk of any damage to the bladder or urethra, although a possibility because we are making incisions to get down to that prostate gland with this one. Really kind of minimal impact on erectile function. and definitely a bit more of a recovery period because we're talking about an incision-based procedure versus a camera-based option or otherwise. And one of the other benefits is we remove tissue here, similar to some of the other options that can be sent for cancerous checks or otherwise. So really, next we're going to cover kind of one of the more exciting innovations in the BPH space over the last 8 to 9 years, which is prostate artery embolization. So Mid-Atlantic Urology, is one of the largest private groups in the tri-state area. Been in negotiations to really bring the service line in a high volume fashion to our patients and the patients of the greater Philadelphia area for some time now. We're excited to announce that this rollout is actually very soon in June 2025, where we're going to be kind of opening this pipeline to our patients with the desire to be really the premier option for patients seeking PAE in the greater area. PAE is done by an interventional radiologist, okay? It's a shrinkage procedure for that prostate gland. The reason the radiologist does this is because they use image guidance to precisely guide areas that need to be treated to shrink that prostate gland. It's done through a small puncture in the groin crease, an outpatient, minimally invasive procedure. So there is no camera, no disruption within the urinary tube or channel. This is done from an outside-in approach to shrink that prostate. A thin, flexible catheter is introduced into the groin crease, and under direct visualization and precise movements, this is kind of wound to the very smallest areas of blood flow that contribute to that prostate gland growth. And a couple small, tiny microspheres are used to plug those selective blood vessels while keeping the blood flow everywhere else intact, to then shrink down that prostate gland globally. So this is a whole gland treatment as opposed to an inside of the prostate gland treatment. You will see in many cases a size reduction to about a third of that prostate size for many patients. Less tissue in the way, better flow of urination. So as that prostate gland begins to shrink, you'll very quickly be able to resume activity and see hopefully less disruption to some of the urinary symptoms that you would see with a transurethral approach. It's an in-office procedure, is done under light sedation, takes anywhere from about 45 minutes to an hour and a half to do this. You are in recovery where we keep you still just for about the 2-hour period when we make that groin crease. That's kind of our standard recovery protocol. And then, typically you'll see resolution of these symptoms pretty quickly after this PAE is done. You may see some temporary swelling on that prostate gland. Again, far less than you would typically see with a directed camera through the urethra that's more disruptive or irritating. Most people will describe feeling like they have a mild urinary tract infection, or UTI sensation with this that will, again, can be treated with medications, but will get better and better over a couple days to a couple weeks. Medications are very effective for managing a lot of those symptoms, actually probably even more so than a transurethral procedure because it's less irritative. Technical success rate is in upwards of 85 to 90%, and that's all comers, even with very, very large prostate glands, because it's so selected and mapped and tailored and personalized to your anatomy. And the other real benefit of this is many patients, because we're not inside the urethra causing swelling, may not require a catheter during the recovery period, whereas almost every transurethral procedure typically will. So, in general, we did a broad strokes overview of how you diagnose BPH, what BPH is, and what many of the exciting innovations from a minimally invasive perspective are for that prostate gland. I will typically, end my presentations with a call to action, which is, I think, really one of the most critical things. If you know that you are experiencing or starting to experience or worried about experiencing these things that are going to happen with some age-related changes to your prostate for you or a loved one, I think it's absolutely critical and pivotal to be engaging with someone who can work with you on that and who can help you to get out in front, so we're not chasing our tail on the back end. So if you are, in need of help in this type of arena, make sure that you partner with your urologist or your specialist or ask for an appointment. Again, my information is here, 215-517-1100. We have many great urologists who specialize in very similar things as I do within Mid-Atlantic Urology. And our goal is to help to give you the best, most sustained outcomes to keep you nice and healthy for years to come. So, at this point, we'll end the presentation, but I'm really excited to be able to answer some questions that have been posed. So we'll kind of go through those one by one. The first question here is, let's see here. All right. Is there a reduction of testosterone with the prostate artery embolization procedure or any of the other procedures? The answer is that none of these minimally invasive options nor PAE would typically have an effect on testosterone. Testosterone generation happens typically in an area that is distinct from the prostate gland that we're going to be interacting with at the testicle level and some of the signals from the brain side downwards. So no effect there on testosterone. The next question is, in individuals who have maybe failed a urolift or an implant surgery or another type of option, what could be some good options to consider to help that situation? So, look, many of these minimally invasive options, Optolune BPH, PAE, especially, you burn almost no bridges by going down a route of getting that as a first line treatment. If you ever were to need something else on the back end, everything is really still on the table. Urolift is one of the unique procedures that actually has an implant on that prostate gland. So, with that one, we sometimes think about certain options being better than others, so we can also remove some of those implants if needed. Aquablation tends to be the way that I handle a lot of those. Is very effective for helping to clear a wider channel and then also at the same time remove those implants. TURP would be another really good option there to also address the implants as well as any kind of residual issue with that prostate gland. Is there a difference between overactive bladder and narrowing of the bladder opening? Well, I generally would say that these two concepts kind of go hand in hand. Anything that causes a bladder outflow obstruction, a narrowing of that bladder opening or bladder neck, scar tissue, swelling along the urethra, and enlarged prostate gland will cause strain on that bladder. That strain on that bladder can cause sensitivity from that high pressure over time. So our goal when somebody has a prostate related issue or anything blocking the flow of that channel is to first address the obstruction, and then many times those symptoms of bladder overactivity will help to resolve themselves. If not, once we've offloaded that prostate gland, many other options become a lot more effective, medication-wise or otherwise, to calm down that bladder and help with an overactive bladder. So I would say first things first to address that outflow obstruction, and then really focus in and delve into whether other options are needed for that bladder. How much fluid does a bladder hold is another good question. I would tell you, listen, that's very different for everyone. It depends on how much your bladder has had to compensate for holding on to a volume of urine that it couldn't completely empty for some men. On average, 300 to 500 cc capacity is fairly normal. But again, some people walk around with much higher volumes and are not necessarily symptomatic. Now, is that necessarily healthy? That's a case-by-case scenario that's important to kind of work with your provider on, to know where you stand objectively and to really be doing everything that we can to keep that bladder nice and healthy. All right, next question. Question is about having tried medication therapy, Flomax or otherwise. They sometimes help with the symptoms a bit, but They also have effects on, libido, sex drive for some of these medications, or production of ejaculation or emission of ejaculation. When you relax that prostate with some medications, um, that ejaculate actually may slip backwards into the bladder, and you may pass it out as urine afterwards. It would decrease the volume of ejaculate for some men. Not all medications have that effect. Not all medications have that effect on certain individuals compared to another. So, if you are bothered by that, option number one is you can try other options for medication, or you can consider some of these other options that maybe allow you to more effectively get off of medication and stay off of medication long term. And many times, those options, if you're considering a minimally invasive option, particularly one of the less invasive options, they do what medication can do much more effectively to boot. All right, let's see the other questions. So a question about finasteride and safety of that medication. The reality is, listen, this is a long-standing generic medication. This is one of the 5-alpha reductase inhibitors that have been around for several decades to shrink that prostate gland down. It is a slower medication to work in terms of safety profile. It's very safe to be taking, actually a very well-tolerated medication, but the way it works is it stops the conversion of one type of testosterone, regular testosterone, to dihydrotestosterone. It's what causes a prostate gland to kind of grow or swell. So by doing that, you may see some effects on libido, sex drive, sometimes erectile function, and in rare circumstances like breast tenderness or otherwise. Oftentimes coming off a medication like that helps to kind of walk those things back. But yeah, I mean, I would again kind of highlight that there are other options out there if you're not as satisfied on that medication. Over the past few years, I've experienced nighttime urination and leakage, not necessarily on a regular basis. I thought it was not due to drinking more fluids or regulating fluids. What can sometimes happen to cause something like that? Well, sometimes it could be related to that pressure on the bladder and not completely emptying your bladder at night. Remember, nighttime is the time that your bladder is going to be most sensitive. So what I would generally say is getting some of that objective workup, like a urocuff, would really give you a much clearer insight as to whether or not this is a bladder pressure issue, and help to direct some of the ways to really move that forward, medication or otherwise. I've heard there's a 10% chance of cancer with 5-alpha reductase inhibitors. Is this true? The reality is some of these observations were never really teased out in any clinically randomized controlled trials. So, these medications in general are well tolerated. They are not cancer-causing agents. Patients with prostate cancer take these medications just as patients without prostate cancer. So my answer is, if you are nervous about a medication or a side effect for any reason, think about some other options that are out there and some other rather good options if that is not something that you're interested in. What is the purpose of the prostate gland? Prostate gland, again, is really a fertility organ. It's meant to help to produce fluid along with the seminal vesicles behind it to help to support sperm. So for fertility purposes. So, it's located where it's located primarily because when ejaculation happens, that emission goes into the urethra and then out through the penis. But by virtue of where it is located, as it's growing with us, it's kind of an inconvenient location too because of how that kind of grows or impinges on it. Are there exercises to help with the prostate gland or bladder? The ones that we cover in the lifestyle section are kind of the most advantageous for bladder retraining. There are formal pelvic floor physiotherapy biofeedback that can be conducted with a little bit more objectivity. Those are things that you can engage with your provider on. Yeah. So, question is kind of a moderate sized prostate gland enlargement with incomplete bladder emptying. What procedures would help me empty my bladder? The answer is that basically most of those procedures we talked about may be advantageous to pursue. It's really when someone comes to see me for a second or third opinion, right, about figuring out what the best option for you as a patient is in a tailored fashion, knowing everything we know about you. So some of those diagnostics that we talked about would really help us to declare what the shape of your prostate gland is, what the contour is, and then how functional is your bladder at this kind of given time, what types of kind of recovery process aspects are really important for you. And we would help to tailor that, but you would have plenty of options similar to the ones we talked about for those parameters. How do you feel about using saw palmetto as a supplement? Look, if there was one supplement or natural entity that I would tell you has at least some efficacy for the prostate gland, it's saw palmetto. You'll see a lot of these formulations out there, super beta prostate gland or otherwise, where they have all these additive ingredients, beta silisterol, lycopene, or other things. The reality is the workhorse is the saw palmetto. Saw palmetto works very similarly to finasteride, which is the 5-alpha reductase inhibitor, but probably on a little bit of a weaker fashion. It slowly shrinks down that prostate gland and keeps it less swollen, but does take some time to work. So consistency is key with that supplement compared to anything else. There's a question about some other therapies for the bladder, axonics or stimulation. There are some therapies that are really more geared towards overactive bladder and would be really good fits or targeted therapies for some individuals based on where they're at with their voiding issues. I would say it's really important to meet with your provider and to talk in more detail about what options are kind of best suited for you given your clinical scenario. Is there an age after which PSA testing becomes unuseful? Look, the American Urologic Association guidelines generally recommend over the age of 75 now to 80 that PSA testing may be less advantageous for people with kind of normal PSA trends over time. This comes from large observational cohorts of patients who, even if prostate cancer were to be diagnosed, right, the likelihood with most prostate cancers is that you may far outlive some of those processes before those ever create a problem for you. And is it necessary to undergo some of the potential false elevations or other kind of diagnostic uncertainty about getting a test, in that age range? My general take on testing is we order testing if it's going to help us to make a clinical decision for you and if it's going to provide meaningful information. And so as long as you're using that as a kind of a guideline, I think it's a case-by-case scenario. And, does age matter? What are some options in patients with, who are older, right, in their 80s to 90s? The reality is that, look, age is a number. And I think biologic age and surgical fitness and fitness for therapy is a very different discussion for everyone. And I would say it's worthwhile to engage with your provider and to really talk, because there are some options that we could consider, even in individuals who are older, right? A lot of those minimally invasive therapies that I spoke about are options that we've done in individuals 80s and 90s. So this is, a situation where it's really important, if something is bothering you, to really kind of get in front of the right eyes to have that discussion and then figure out the best tailored approach. So that looks like all of our questions here. You'll see a link here. You can always request an appointment with me or other individuals within Mid-Atlantic Urology. Again, our whole goal is to figure out how to best take care of you and partner with you to figure out the best solution for you. I think that's really an important thing. We work together on this and help you to kind of understand what is important and what some of the considerations that we know about are to really help to make meaningful change in your life. So thank you again for your attention tonight and spending time with me. And if there are other questions, please reach out to your provider and urologist team. All right. Take care and thank you.